Hello, my name is Sonia Bernardes. I am an associate professor of ISCTE, University Institute of Lisbon, and in this short video, I'll be talking about sex and gender biases in pain research and clinical practice. So please join me in this short video as I explore key evidence-based insights from the recently published fact sheet by the International Association for the Study of Pain that I had the privilege of co-authoring alongside Anka Samulovitz, Kai Karush, and Jeffrey Mulgill. But let's start by clarifying what we mean by sex and gender biases in pain research and clinical practice. So, sex and gender biases describe a tendency to favor or unfavor a group of individuals over another based on their sex or gender categorization. These biases are often rooted in stereotypes, prejudice towards men, women, or gender diverse people, which may lead to discrimination. And in patriarchal societies, sex and gender biases often favor men over women and gender diverse people. But are there sex and gender biases in pain research? The answer is yes. Preclinical studies of pain have been historically performed mostly in male rodents due to the fear that cycling gonadal hormones such as estrogen and progesterone would lead to higher variability in data, needing the use of more animals and raising research costs. This fear has been shown to be unfounded in studies of pain specifically and in biomedicine in general. So because the use of male rodents to model conditions overwhelmingly affecting women is unethical, many funding agencies around the world have been instituting sex as a biological variable mandates, that is, policies recognizing sex as a variable to consider in research design, analysis, and reporting. We can also find sex and gender biases in clinical research. Most current pain theories do not integrate sex and gender factors. Most pain research with humans does not analyze nor report sex and gender differences. And although recent studies have a more balanced representation of the sexes, sampling biases can still be found. Furthermore, assessment of demographic characteristics is still often unable to tap the diversity of the sexes and gender identities, going little beyond female, woman, male, man, and other. Also, dominant stereotypical sex gender binary views still shape most research conceptual assumptions and designs. And what about clinical practice? Are there sex gender biases in clinical practice? The answer is also affirmative. A large systematic review in emergency medical settings showed that women are quicker in recognizing symptoms of acute coronary syndrome, such as chest pain, but wait longer to access the emergency medical system after seeking help compared to men. There was no clear consensus in this review on sex gender biases in pre-hospital interventions for acute coronary syndrome. Another systematic review showed that women report higher postoperative pain than men in most studies, but received less pain medication than men in more than half the studies. In chronic pain contexts, another comprehensive review showed that in clinical encounters and compared to men, women struggle more for their pain to be seen as legitimate. Women's pain is more often psychologized, mistrusted, judged as unreliable depending on their appearances, and women receive more referrals to psychological treatments, less effective pain relief, fewer opioid analgesics, and more antidepressants. This review suggests that pain-related gender norms might be accounting for these biases. What are pain-related gender norms? These are stereotypical expectations regarding how women and men are and should behave when in pain. And this review shows that there are widely shared expectations that in public spaces, men with chronic pain are stoic, autonomous, in control, pain tolerant, avoid talking about pain and seeking help, whereas women with chronic pain are expected to be more sensitive to pain, more willing to report pain, and sometimes as hysterical, malingerers, or feigning the pain. Noteworthy, some evidence shows the absence of biases, or even, although less frequently, biases against men in clinical practice. So this suggests that sex-gender biases in clinical practice are most likely variable and context-dependent. But how can we minimize sex and gender biases in research and practice? First and foremost, researchers can start following guidelines and recommendations to integrate sex and gender in research. For example, you can find the sex and gender-based analysis proposed by the Canadian Institute of Gender and Health, or the Sex and Gender Equity in Research Guidelines, the SAGER guidelines. You can also find very recent recommendations on how to embed a sex and gender perspective in pain research by Keogh and Berner. What about clinical practice? The first step is to raise awareness. There is currently a lack of effective evidence-based interventions to overcome sex and gender biases in clinical practice in general, but you do find a few tools to promote and facilitate an ongoing analysis of gendered processes in pain care through questions addressed at workplaces and health professionals. So if you're interested in delving deeper into this topic and checking your facts, please consult our fact sheet that you can find at IASP website and help us raise awareness about this important topic. Thank you so much for your interest and attention.